Well, and now to begin, our dear Dr. Fernández-Vega, please do your hand-to-hand with the professor. Give us the entrance, the introduction, and the presentation of this great professor here in Oftalmo University. Okay, thank you very much. All you know Dr. Alfonso, but I'm going to make a summary, some of his achievements. He's actually head of the cornea lens and refractive surgery of the Fernández-Vega Ophthalmological Institute in Oviedo, associate professor of the University of Oviedo, author of many chapters and articles of ophthalmology and some books. Please be aware of the Society of Ophthalmology that it's going to come up in September, and I think it's going to mark a before and after in phaco-refractive. He received the most important awards of Spain. That's Arruga and Castrovieja. He was president of Secoir some years ago. And the most important thing for me is that he was director of my doctoral thesis and my main mentor. He's a great surgeon, a great researcher, a great person. And today he's going to give us one of the greatest corneal advances in the last years, and that's going to help us a lot in the future. We would like to thank AJL and its staff, who from the beginning believed and supported this project, and without them it wouldn't be possible to be here today. Okay, Dr. Alfonso, when you want, in a minute. Everybody sanctions. Ivo, Lisandro, do you want to add something else? Well, I want to highlight that to thank the whole panel. For me, it's a history to be here, to be talking about technological innovation with his creator, with his team that helps him, with all his institution. We have here 3 languages. We have all the community of ophthalmologists, so today is a joyous day for all of us. Well, let's go. Good afternoon to everyone. Good night from Spain, or good morning. The idea really is to make this webinar, to make this collaboration with Oftalmo University. It was an illusion for us. It's an idea that we share, and we want to move on forward. And thanks the organizers, to all of you, to the youth that keeps the old guard in activity and working and researching. I'm going to present to you the ENDO-K PRO thesis. That's a new concept in corneal transplant. I'm going to present this talk, all what I know about it. I can assure you that nothing has been left to say. And I'm going to present that in this webinar in such a way that I'm going to explain all of what we can say up to date to the Endocaratoprosthesis. It's a new concept of corneal transplant. The initial idea is, as always, a research question. Is it possible to avoid the penetrating transplant in cases of bad prognosis? Developing an alternate technique of laminar origin. Based on the laminar techniques, we can improve the prognosis of a penetrating transplant that we know that sometimes goes wrong, like the ones I'm presenting you in this slide. The objective is not to perforate the cornea, and we'll know that when it's perforated, there can be more complications. What background do we have of this idea? Well, in years 1991, 93, as you can see in the references, in the cases of bullous keratopathy treated with laminar transplant, these authors wanted to make a laminar transplant with full thickness grafts, and what they wanted was to recover the morphology of the cornea. But in these cases, there was just a transplant, a therapeutic transplant. The authors saw that if the receptor adheres to the donor endothelium, the graft is going to fail. But if a pseudo chamber was formed, the graft will survive. A full thickness transplant on a residual bed, if the cells of the donor endothelium were united, it failed. But if the pseudochamber was maintained, the graft survived. The procedure was abandoned because it was just a reconstructive procedure. And as you see, this idea had not been resumed since 1993. Other previous experience that leads us to the technique are the cases of pseudochamber that forms in Dalk's technique. As it's well documented in the year 2019, there are articles about it, and as we see, are pseudochambers that are formed in 8% of cases, in between 5 and 10%, and are frequent, these pseudocameras or double chambers, where there's a microperforation, or when the big bubble type 2 technique is performed. And it's really considered as a complication of the Dalk surgery. Well, with these two previous experiences, the objective that we can have now is to make a transplant of full thickness without perforating the cornea based on the usual Dalk technique. The idea is to create and intentionally maintain a separation between stromal receptor bed and the donor corneal endothelium, as you can see in the slide. The idea to develop this procedure with the possible alternatives and evaluate its safety and efficacy short and long term. In the first phase, we developed what we called the transplant protected by pseudochamber, the PPK. In step 1, we make a Dalk conventional technique. In step 2, we make a full thickness transplant with the endothelium, and in the step 3, you inject some OVD in the pseudochamber to maintain in the post-op. What would be the advantages of these procedures? Are intraoperative advantages because the surgery is in closed chamber. You can associate other technical techniques, and the post-op are the same as the ones that you have with Dalk. You have a morphological recovery of the receiving cornea and inflammatory immunological isolation of the donor cornea thanks to the pseudochamber, and lower risk retransplantation, as well as lower risk of endophthalmitis. The idea is to keep the donor cornea isolated from the contents of the eye. The pseudochamber isolates it. What would be the drawbacks of this technique? There are two. The first is the tendency of the pseudochamber to collapse. That depends mainly on the values of the intraocular pressure. The trend continues during the first 3 months until the stromal bed becomes fibrous, gets rigid. And as you can see in the last picture, in this last slide, we need to inject cohesive OVD repeatedly from 1 to 3 times in the post-op during this month so that the residual bed does not stick to the donor cornea. Here, as you can see, there's a case in which there's a tendency of this chamber to close, so we are injecting OVD to separate it with intraoperative OVD. You can see how the receptor bed has been separated from the donor cornea. With these maneuvers, we can damage the endothelium if you do it repeatedly. The other disadvantage is the visual limitation due to the presence of the stromal bed. But it's a relative disadvantage because there are patients who usually have poor potential visual acuity, and of course, it's acceptable in cases of aphakia, for example, with intraocular silicone. And in cases with good potential visual acuity, we can make an endotelectomy. That is a hole that can be made in this residual bed with scissors or with a femtosecond laser. Here you can see a video in which we're making the endotelectomy with femtosecond laser. It is the one that we use for capsulotomy in cataract surgery. We can, in quotations, fool the laser and make it act at the bed level. As you can see, with a vitrectomy forceps, we can remove the residual bed that we have left if the visual prognosis of that patient is good. Then, with these ideas of the surgical technique of the transplant protected by pseudochamber, then we proposed the second phase of our project. That's the Endocaratoprosthesis. That's really an intracorneal implant. This is a joint project of the Institute and the Spanish company AJL. That in this case, we did the concept and the initial design of this plastic element that we're going to show you. And AJL did the optimization and manufacturing. The clinical trial began in August 2018. We have 2 years with this clinical trial. And the initial sample, then afterwards we will see the cases. We have now more, but the initial sample was 10 cases. The patent was in February 2019, and the CE marking was in June of 2020. And for that precisely has been now the launch at the level of using the Oftalmo University platform to launch the platform, because up until now we could not talk about this international. The prosthesis, as you can see, there you have a diagram. It consists of a peripheral ring and an optically neutral central disc and 4 connecting radius between both. The peripheral ring and the disc are in a different level, with the idea, as you can imagine, of pushing the bed backwards. The material of the prosthesis is PMMA, you already know it. The objective of the prosthesis is to avoid the collapse of the pseudochamber. And you can see there in the first picture of the prosthesis, you can see the cornea, the prosthesis, and the pseudochamber, and behind the prosthesis, the residual bed. What indications do we have for the keratoprosthesis? Well, an uncertain prognosis for any type in the cases that we have a penetrating graft that we know that's going to go with problems. Really, there are cases that we don't know how to effectively solve them. We can think of bullous keratopathy after complicated surgery with anterior synechia, aphakia, pseudophakia, silicone bulb, Fox dystrophy with stromal fibrosis, any morphological alteration of the anterior chamber, of course, infections, caustics, limbic insufficiencies, anything that has problems on endothelial or important trauma, or also failed transplants, previous failed transplants. You can also use them in these patients that have had transplants, failed transplants. The sample, or let's say the presentation, it's like a paper. The patients, the selected patients have been 17 patients that have undergone the implant. In 8 cases, the cornea didn't have a previous transplant. The cornea may have edema, fibrosis, neovessels. It can be altered, as you can imagine. The lens, it could be, the patient could be aphakic, pseudophakic, and the intraocular pressure, we can have it in any situation, controlled with medical treatment or previous surgery. We have had also cases with Ahmed's valve. In the retina, we can also have previous vitrectomy with silicones, etc. Also, we have patients with previous transplant. And here I've divided the transplants into groups. 2 cases with previous reconstructive dots and 7 with failed penetrating transplants. In the cases of dot were patients, aphakic patients, and that have a retinal problem, that they have had surgery, and they have had silicone in vitreous chamber. The failed penetrating transplants, as you can see, the lens is no problem. The patient can be aphakic or pseudophakic, and the same as before, the intraocular pressure can be controlled or not. In the retina, we can also find any other situation. So, if you realize any situation that we may find within the eye, it's likely to be a selected case for the ENDO-K implant. The surgical technique, step 1, would be a conventional dog technique, completely conventional, just to highlight that the stromal dissection is best done manually until predestimate, leaving a residual bed between 50 to 100 microns. It's not necessary to risk that because really what we want is not to perforate the cornea. That's something very important, not to perforate the cornea, so we don't have to risk the dissection. I think that the big bubble would not be advisable due to the possibility of a microperforation and due, as you see in the diagram, a peripheral corneal pocket of about 0.5 millimeters. The second step would be the implant of the ENDO-K, as I call it usually, and for that we place the peripheral ring inside the pocket so that the central disc pushes back the stromal bed. Then make a suture, a provisional suture of this ENDO-K to the pocket to facilitate the suture of the graft, as we will see in the video later. The third step would be the suture of the graft full thickness above the ENDO-K and filling the suture chamber with BSS and or OVD. Here you can see the surgical technique. As you can see from June 9th of this year is the last ENDO-K I've implanted. It's a lamellar dissection, conventional, with Melis spatulas. We're looking for a deep layer. We can do an intraoperative pachymetry. It's appropriate that we have between 60, 70, and 100 microns. We're making the peripheral pocket, and we're placing the prosthesis, as you can see, with its peripheral ring, the central ring, and the radius that join them. We're doing with an 8-0 silk suture. We're using one of the radius to fix the peripheral ring to the pocket. By pulling with that suture, we can easily place the peripheral ring in the corneal pocket that we have created. Once the implant is fixed and it does not bother us, we proceed to the suture of the cornea, full thickness cornea. It has its endothelium. We make the first fixation points, then we release the fixation suture of the prosthesis, and we complete the suture like any conventional lamellar surgery. The suture goes above, I insist, above the peripheral ring. Last case that we make, it was in June. I'm going to show you the first, the one that we did. It's a patient that I feel very affection to because it was a patient that we maintained. It was a unique eye, only eye. We kept the structure of the eye by doing conventional lamellar transplants, repeated dog techniques. And the last one, we had an infection, and since we had the procedure dog, previous dog, to implant the prosthesis to keep the suture chamber was a technique, a simple technique. At the beginning, we used nylon 10 zeros to fixate the prosthesis, but now we prefer to use the 8-0 silk that's more resistant and allows us to introduce the ring, the peripheral ring, in the pocket. As you can see, once that's fixated, the ENDO-K, the initial suture, we take off those sutures of fixation, and then we complete the suture with the 16 stitches. This was a case. It was a very important option because you can keep a cornea in good shape with dog transplants until you can make the ENDO-K technique. The idea is, I insist, that there are cases that if you perforate them, you will have short or long-term complications. The suture, as you can see, it's a conventional suture above the peripheral ring. Then in the post-op, what can we find? As you can see, here are some examples. We can see the cornea, the space of the suture chamber, the central disc, the radius of the ENDO-K, and the residual bed. The bed that will be much visible depending on the thickness you have left. If you have left many microns, it will be denser, more opaque. And if you have had left, it's practically like a capsular opacity of a cataract. What happens? Now we can have two options. As we said with the technique of PPK, the first option is to keep the stromal bed, receptor stromal bed, to protect the donor cornea from the intraocular pathology. We're not interested in opening the bed. If we have intraocular silicone, we are not interested in having the silicone in contact with the donor. Our option 2 is to remove the residual stromal bed if the intraocular condition allows it. If the condition allows it, you can take the residual bed. How can we do it? Depending on the thickness we have, we can do it with ventolaser or vitrectomy scissors. It's a technique that's not technology dependent to make it. And any of these possible options. You can do it with femtosecond laser for convenience, or also with scissors, vitrectomy scissor, or with jag laser if it's necessary. Here I'm going to present you a video how we do it with a femtolaser. As we did it with the PPK, we're working with the laser below the disc that's optically neutral, that has the implant, and with a forceps, vitrectomy forceps in this case, where through the limbus we make the extraction. As you can see, the plaque or the plaque of the ENDO-K is closing that hole, that central hole, that didn't occur when we make the technique without the ENDO-K. This would be the aspect after the surgery. This is a series of patients who did the endothelectomy. The chamber, you keep the chamber, you can see the impact of the laser in the disc, and you can see that the transparency has improved of the visual axis, the transparency in the visual axis. The disc of the ENDO-K, it's important that it can maintain isolated the pseudo-chamber from the intraocular content. And afterwards, the explorations that we like to do, it would be an OCT to see the tendencies of this pseudo-chamber, if it has a tendency to collapse or not. Here you can see in some cases there are synechia between the iris and the residual bed that could make a failed penetrating graft. The endothelial cell count, you can do it, and also the intraocular pressure. Take the intraocular pressure. Of course, I don't want for you to get bored with numbers, but for you to see how we're developing the project. These 10 cases that I showed you in this first tape chart, the orange are the ones that had a previous corneal graft. If you can see the endothelial cell count 3 months afterwards, the media is of 1,600, and it's very good for a transplant if you compare it with a penetrating graft. And 6 months in yellow, the cases in which we remove the residual bed. If you notice, there is a loss of cells in the cases. We did the removal of the residual bed, around 1,300 cells, but in the eyes that we did not do it was 1,800. 12 months afterwards and 18 months afterwards, if you can see, the endothelial cell count are very, very good level. 12 months, 1,500, and 18 months, 1,171. And if you can see, between the month 6 and month 12, we've done 2 more extractions of the residual bed. That's the tendency we have now. At the beginning, really, I think it was a sin to try to improve the visual acuity quickly. So we've learned to wait a little bit more, to have 6 months at least, because the cell loss is much lower. That's what we have been checking. And if you notice what happens with 3 cells that they're without data, well, those are 2 cases of regrafting that I have to do. 2 patients that have previously a transplant in which the initial pathology has recurred. One was an infection, and the second case was an herpes relapse. Maybe it was a lack of preventive treatment in this patient, taking a look at the medical record. Also, at 18 months, you can see there's a patient that has edema, because it's a patient that the intraocular pressure was not properly controlled, and the residual bed was was occluding the pseudo chamber, and I did not inject OVD, so there was a contact between the radius of the prosthesis and the residual bed, and at the end, finally, I had a corneal edema that I have to solve with another retransplant in next month. These are the cases. I'm going to tell you very honestly the follow-up of the 17 cases I have. These are the 7 cases after the clinical trial. As you can see, I keep on making cases with previous unsuccessful transplants, and I can tell you that the count at 3 months of the cornea that are currently operated is around 1,800 cells. And if you can notice in this chart, there are 2 details. There's a cell that says visco OCD. In these patients, if I see the tendency that pseudo chamber is going to collapse, then I make an injection of OVD. The same as I did with the PPK technique. If we make the bed very thin, we're going to do a lamellar technique, leaving around 50 microns of bed. Logically, it's more mobile and has a greater tendency to go towards the donor. Also, you can see how the removal of the residual bed is reserved for later, around 6 months. 6 months better than 3 months. Well, with this data, I simply show you a sequence of some patients. This is a case in which didn't have a previous transplant. It was a complicated cataract surgery, and you see the sequence of all the follow-up of this patient. 6 months, as you see, 12 months. 12 months, we have removed the residual bed, and the cornea remains transparent, clear. Here, I show you the cases that have not done well. This is a case I told you about. It was an edema of the central cornea, and it's pending another transplant, another graft. In this patient, we see how at 3 months he had the residual bed, and at 6 months we removed it. We did not realize, or we did not give the importance, or maybe we waited too much to inject some viscoelastic, some OVD. So there was a delay, and there was a peripheral contact of the stromal bed with the donor cornea, and edema appeared. This is the case that we will have to do a transplant again in short term. These 2 cases are very interesting because they are the 2 cases. The case of a reconstructive dog, a previous reconstructive dog, is a patient that it was operated in August 2018, and there was a reconstruction of the cornea with a dog technique. We made the implantation of the ENDO-K. You can see the pseudo chamber. Then we removed the residual bed, and 18 months afterwards, it still is transparent. If we have done a penetrating transplant, considering he had intraocular silicone, that graft it was going to fail. So we make a dog, then reconstruct the cornea that's completely altered, and then if it's necessary, you can use the ENDO-K. This is the case I told you at the beginning of the infection. And this was a dog that it has no stitches. It was a long time follow-up. It was more or less transparent, and it was opaque. It was infected, and then this is the sequence: 6 months, 12 months, and 18 months. And the patient is seen through the endoprosthesis. In this case, I present a patient with a failed penetrating transplant. She was operated in September 2018. The follow-up, the same as before, 6, 12, and 18 months. And at 18 months, he begins with a peripheral edema. This edema, it's because in the cases of penetrating transplants, I cannot make a pocket in the cornea because I find the scar of the transplant. Since the diameter of the prosthesis is a fixed diameter, then in this case, he has no pocket where I can introduce the peripheral rim. So that rim, it's in contact, continuous contact with the cornea, with the donor cornea. What advantages can we have of this technique? Well, the intra-op, the surgery is done under closed chamber, and we can associate other surgical techniques. As you can see, this patient, we have made the dissection, the lamellar dissection. We've reached a level to operate the cataract, so we see how we're introducing the intraocular lens, and then afterwards how we can place the prosthesis in the pocket and ending up the transplant. So it's a technique that allows the cataract surgery, and we can associate other intraocular surgical techniques, such as in this case that we did a vitrectomy secondary to epiretinal membrane. That central disc, once you have removed it, and without removing it also sometimes, but removing it facilitates retinologists to access the posterior pole and even perform surgery on an epiretinal membrane. What are the advantages, the post-op advantages? I don't insist on them. They're the same as dog, and the thing that's very important, that we have had no case of extrusion of the ENDO-K. No extrusion of the ENDO-K. What inconvenience? Intraoperative, anything relevant. Maybe the predesmatic laminar dissection that has to be done manually to reach that layer, not to use the big bubble. And in the post-op, the tendency, the natural tendency that the pseudo-chamber has to collapse. That happens in the first 3 months. In this period, this pseudo-chamber has a tendency to join, to close, and for the two corneas to adhere. The control of the intraocular pressure in these cases is very important, because this tendency clearly depends on the intraocular pressure, and there's no need to hesitate to introduce a little, some viscoelastic, as we did with the PRK, because really sometimes we need it once or sometimes 2 times to introduce the OVD. We are going to comment at the end in these cases of high intraocular pressure. We would like to have more rigid prosthesis for some patients so that they can give a better support to that intraocular pressure that has not been sufficiently controlled either before or after surgery. The other drawback or inconvenience would be the loss of endothelial cells that we have seen with the surgical removal of the stromal bed. In this sense, we have to very well justify the need to perform this endothelectomy, which can be done with femtosecond laser, JAG laser, or vitrectomy scissors, because it can induce a loss of endothelial cells. If the prognosis of that patient, visual prognosis, is good, you can do it. But if it's really a patient that has a very poor vision, a vision of 0.1 or 0.05, sometimes it's more interesting to maintain the bed, especially the intraocular cause persists. What happened with the corneas that had previous transplant? We think they have a worse prognosis, but not for the ENDO-K, but because of the control of the initial condition. That's important to manage, of course. And it would be advisable to have prostheses of smaller size, because these corneas that have had grafts, previous grafts, can have diameters of 7.5 or 7, and it would be good to have smaller prostheses. These 2 cases that I've told you that I have to regraft, as you see, the surgery has been completely calm. You can make a new graft without removing the ENDO-K. The ENDO-K was intact within the pseudo-chamber. It was in the periphery of that transplant, and to place another cornea above the ENDO-K is not, it has any other risk. The chamber remains closed. Therefore, and this is the development that we want to carry out of the ENDO-K in terms of surgery. It's look for that ideal residual bed, less than 75 microns, because maybe you have better visual performance. Maybe it's easier to make the opening with JAG laser of that bed, but maybe it can be harder to reach layers of 50 or 60 microns. But the important thing is not to perforate I insist not to perforate. We should not take surgical risks. Regarding the prosthesis, version 1, which is the one I have shown you, is the current design. Version 1.1 would be different diameters for cases of penetrating transplants that we need smaller. Version 1.2 could be to give more rigidity to the ENDO-K, especially for those patients who have high intraocular pressure, or the thickness of the radius, or the number, or the angulation. These are for certain cases in which we have not been able to control the intraocular pressure. We have to consider that the technique in itself, it does not induce changes in the intraocular pressure because we have not entered in the anterior chamber. Version 2.0 would be refractive correction in the central disc for the cases of aphakia. It could have the necessary correction. The version 2.1, we have think about ENDO-K with a central ring instead of disc for some advantages that we could give to some patients. Therefore, we have also planned the evolution of the implant. As conclusions, what can we say? Well, it's a full thickness transplant, which is not perforating. That's the fundamental key. It's a non-perforating and carries the ENDO-K implant between the two corneas, between the host bed and the donor. It's a new concept that does not require, it's a technique that's a common technique that we've used to do. The intracorneal implant of PMMA is well tolerated. The ENDO-K, the material, it's very well tolerated. It's an effective procedure. We have been able to handle patients that we did not know how to solve. The easiness of regrafting, of retransplantation if it's necessary. If we need a retransplant, we can take the donor cornea, but the structure of the ENDO-K, of the bed, we don't have to touch it. And it has both technical and biological possibilities of development. And the last sentence that it summarized the whole philosophy is that ENDO-K could be the prosthesis in the era of laminar transplants. It's perhaps one of the most important innovations in this regard, be able to work on laminar transplants without having to perforate the eye. Well, nothing more to thank Oftalmo University, and especially also to the organizers, and of course, thank our collaborators, AJL, that has believed in our project and has manufactured and plans to market the prosthesis. Thank you all.